Thanks, Mark. I'm Richard Griffithson. I'm the ASO President. I've spoken to most of you before, unfortunately been able to meet a lot of you at this meeting. I'd like to welcome you today to the grand final day plenary session. And our first speaker today is Professor Colin Mackenzie, who's already spoken at this meeting, and I had the privilege of hearing his talk on video task analysis in the emergency room, which was absolutely fascinating. Colin's from Sheffield in the United Kingdom originally, but he spent the last 25 years in the United States. Despite this, he seems to have either developed or maintained a delightful mid-Atlantic accent, which is more reminiscent of Bill Bryson, or I think the late Alistair Cook, many of you will be familiar with, as a very famous BBC correspondent based in New York. Colin is Professor of Anaesthesiology, Associate Professor of Physiology and former Director of the Charles Matthias Jr. National Study Centre for Trauma and EMS. This is the primary research centre for the Maryland Emergency Medical System. His research interests include trauma resuscitation, haemoglobin-based oxygen carriers, telecommunications and human factors in emergencies and disaster response. Colin is an experienced trauma clinician with more than 35 years' experience with the Maryland Emergency Medical Service. I spoke to Colin after one of the meetings a couple of days ago, and he was talking about gunshot wounds in the emergency room. And there are two types of gunshot wounds in American emergency rooms, and most of them relate to disputes related to the retail pharmaceutical industry. The first type are people who are shot outside the emergency room and come in and are treated and resuscitated. The second type of gunshot rooms are those that occur inside the emergency room, and these occur when the perpetrators realise that they haven't done the job properly and come into the emergency room and try and finish it off. As a result of this, getting into an American emergency room is a bit like getting into an airport or, in our case, Parliament House tonight. I'd really like to extend a very warm welcome to Colin to present his plenary lecture, Haemoglobin-based Oxygen Carriers, Myths, Reality and the Future. Thank you, Colin.
Thank you very much, Richard, for a wonderful introduction. I thank you also for the Australian Society of Anaesthesiologists for inviting me here, Paul Burt and Mark Scasel for their organisation. It's been superb, a most enjoyable meeting. Thank you. So what I'm going to talk about today is haemoglobin-based oxygen carriers, myths, reality, and the future. I put my email up there in case you have any questions you want to ask. I do have to declare a conflict of interest. I'm going to talk about Haem-115 study, which I was a site PI on. Also, I have been a consultant for OPK Biotech, who manufacture Hemopure, which I'll also be talking about. It's especially interesting for me to be here today because over 80 years ago, my father came aboard the Jarvis Bay as the ship's doctor, and you'll see him on the right in that group of officers up there. And they went through the Suez Canal, they went around Cape Lewin, and I think probably at the bottom you can see the Cape Lewin lighthouse just there. Their first port of call was Melbourne. They're seen arriving here and departing here. Note the square rigger sailing ships in the background. And then they went up to Sydney. Note the incomplete bridge in 1932, under the bridge there. And his first shore leave was in Brisbane. As you can see, he made full use of the shore leave. And I have to admit that the admiring glance of this young lady here at my father, the photographer, makes me think, had he lingered a little longer over the watermelon, I might have been an Australian. So that was in the past. The Jarvis Bay, incidentally, as many of you may know, became a very famous boat in World War II with the Atlantic convoys, but that was in the past. Today, we're going to talk about identifying some of the capability gaps that haemoglobin-based oxygen carriers might fill as an alternative to blood. to describe the compassionate use series for one product, Haemopure, and discuss the transfusion sparing capabilities and compare the available hemoglobin-based oxygen carriers. Then I'll briefly describe some of the results of the prospective randomized clinical trials, the phase 3 trials of the two products, Haemopure and Hemospan, otherwise known as MP4, and then summarize the status of hemoglobin-based oxygen carriers in light of this JAMA meta-analysis that proposed that all hemoglobin-based oxygen carriers increase mortality and cause myocardial infarction, and that there was a class effect of these hemoglobin-based oxygen carriers. And then lastly, what is the risk-benefit status of using these products? So here's a capability gap that a hemoglobin-based oxygen carrier could fill. This is a 23-year-old male who was admitted to the University of Maryland Shock Trauma Center where I work. He had been struck by a motor vehicle, and you can see he has a left acetabular fracture, iliac wing fractures, diastasis of the symphysis pubis in both sacroiliac joints. He was a Jehovah's Witness, and he refused blood. So he was also had a grade 3 liver laceration. He had bilateral iliac artery tears and had retroperitoneal hematoma and a hepatic artery bleed. This slide here shows you what happened to him, and I'm using grams per deciliter for hemoglobin, by the way. And that's on the left y-axis, and hematocrit is on the right axis. So blue is the hemoglobin, red is the hematocrit. So at point 1, the patient came in, had a hemoglobin about 13.5, and was resuscitated in the conventional way with crystalloids. And if you can see in the right-hand side of the graph, the lactate continued to rise despite crystalloid resuscitation, suggesting that he was in uncontrolled hemorrhagic shock. At point 2, we obtained IRB and FDA approval, and of course the patient's consent to use a hemoglobin-based oxygen carrier. He received 150 grams of the product, and at point 3, you'll notice that the total hemoglobin has risen, but the hematocrit has fallen. So these are acellular solutions, and so you, as it were, hemodilute the red cells that are resident within the circulation, but increase total hemoglobin due to the plasma hemoglobin. And at point 5, you'll see that the patient spontaneously started to generate his own cells, and this is due to hemopoiesis that results about a week after you have given the product. He was extubated on day 8 with a hemoglobin of about 7, underwent percutaneous pinning of his acetabular fracture and other pelvic fractures, and was discharged on day 14, walking on crutches. He did very well. Another example of a capability gap. This patient had acute idiopathic hemolytic anemia and received 53 units of Haemopure over 19 days. As you can see at the bottom, this patient was essentially a bloodless human, was sustained alive for about 17 days with all organs functioning, patient responding, had all efforts to try and reverse the hemolytic anemia, including splenectomy, but this was unsuccessful, and so therapy was stopped on day 18. So we looked at a series of these so-called compassionate uses of this product, Haemopure, and patients with an average hemoglobin of 4 grams per deciliter. Of them, 42% were discharged from hospital. And the factors that made it likely that they would be discharged were the level of hemoglobin at which we were able to start the administration of the hemoglobin-based oxygen carrier, and something we referred to as the hemoglobin deficit duration, was greater in non-survivors. In other words, the dose of low hemoglobin was greater in the non-survivors. So there's a lot of administrative things associated with getting approval to give these products because they are not FDA approved in the US. So it took us sometimes as long as 2 or 3 days to get this approval. And the things we noticed during the administration of these products and the compassionate use was that patients do appear jaundiced. Of course, hemoglobin is metabolized through the usual channels, and you're giving a large protein load, so some of the liver function tests may be abnormal. There is free hemoglobin, as in the hemoglobin solutions, does bind nitric oxide, and so there is some increase in blood pressure. You can, of course, use a nitric oxide donor, such as nitroglycerin or sodium nitroprusside. There are some bowel symptoms due to binding of nitric oxide with feeling of bloating, nausea, vomiting, dysphagia. You can, of course, give anticholinergics to reverse that fact. The biggest factor, though, was this point of half-life of the product. It is a drug. You've got to think about this as a drug called hemoglobin. And the redosing of that is a very important part of the use of this product. And during these compassionate use studies, we found that continuous infusion of the product was a much better way to sustain the total hemoglobin than using intermittent boluses. It does interfere with bedside monitoring and laboratory monitoring because of methemoglobin and because of the free hemoglobin in the plasma. You're liable to get results back saying specimen hemolyzed if you send it to the lab without telling them that this is a hemoglobin solution. And the methemoglobin can cause reductions in oxygen saturation, but then you just use co-oximetry to get direct measures of oxygen saturation. The methemoglobin also can rise 5 to 10% sometimes, and the traditional methylene blue may work when the hemoglobin is high, but when the hemoglobin is very low, less than 4 grams per deciliter, there just isn't enough methemoglobin reductase because there's very few cells, and therefore ascorbic acid should be used. So what about the transfusion-sparing capabilities of HBOX? Well, at the University of Maryland Shock Trauma Center, we transfuse roughly 8% of the patients who are admitted each year. But 72% of the blood that is given to the people who have massive transfusion. In this slide here, one patient had more than 120 units of blood. But of the remaining patients, the most common mode of transfusion is a 2-unit transfusion. And this data is the same across all the major trauma centers in the US. A 2-unit transfusion is the most common mode of blood transfusion. So that if we were able to replace this 2-unit transfusion with a hemoglobin-based oxygen carrier, even in 1/4 of the patients who have trauma in the US, we estimate we could save at least 100,000 units of blood per year. The point is, when patients are going to die of hemorrhage, they die extremely quickly. This has been the evidence from Afghanistan that hemorrhaging patients with penetrating injury die very quickly. These are our data from the Shock Trauma Center, and the blue trace shows you that over half the patients who are going to die a hemorrhagic death are dead within the first 3 hours after admission. So we need to have a product that can be given very rapidly. So we do use a lot of uncross-matched blood in the Shock Trauma Center. And again, this is a potential use for a hemoglobin-based oxygen carrier to temporize the oxygen carriage while efforts are made surgically to control the bleeding. So the capability gap then potentially for hemoglobin-based oxygen carriers under the indication of blood not available or an option in early hemorrhage would, of course, be trauma. Postpartum hemorrhage, a lot of women die of postpartum hemorrhage worldwide. And there are many surgeries that blood may not have been prepared where they get into bleeding difficulties. So this is a product that could be potentially immediately available. In the field, in remote locations, disaster situations when blood is short or available supplies are depleted, or when blood cannot be given, the hemolytic anemias or antibodies. About 3 weeks ago, I was consulting on a lady in Canada who had sickle cell disease. She was 26 years old. She'd had so many transfusions in her 26-year-old life that there was not a single unit of blood in North America which she could match. So we were able to get some hemoglobin-based oxygen carrier to her. And then, of course, if blood is refused on religious grounds, then it is an alternative. So when we look at the use of conventional blood products, we know that they can be stored for 6 weeks. In fact, the FDA, I believe, has just approved up to 8-week storage now of regular red cells. They can be frozen with glycerol, and you use glycerol to stop the cells hemolyzing. You can also lyophilize them, that's rapid freeze drying, and if in Afghanistan, the Australian Defence Force and the Dutch Red Cross are using lyophilized universal donor products. Or they can be sprayed dried, that is, the kinetics of drying are so fast that the red cell doesn't have time to die. As regards oxygen-carrying solutions themselves, perfluorocarbons and encapsulated hemoglobins are no longer available. They are toxic. They produce reticular endothelial problems. As regards the perfluorocarbons, they just don't carry oxygen. So recombinant hemoglobin is an interesting product, extremely expensive, difficult to make, never been produced in sufficient quantities to allow a clinical trial to be done. But as a research probe, a very interesting product because you can modify it in different ways and test different possibilities as regards to toxicities. So that leaves the modified hemoglobins, which could be basically conjugated. They can be polymerized, or they can have additional large molecules added onto them and the end objective of this modification is to increase the retention time within the circulation. When you take a human hemoglobin and you take the red cell off it, the P50 changes quite dramatically. And so you have to pyridoxylate those products in order to make the P50, the oxygen affinity, more normal. If you use a bovine product, when you take the cell wall away, the P50 still remains about 40. So you don't have to do that modification in the bovine products. And I should say that I'm using the term milliliters of mercury for P50. I'll have to explain that later. So myths and realities. These are not blood substitutes. This is the standard terminology that people use. This is a blood substitute. Blood has many, many, many functions. Hemoglobin-based oxygen carriers have 2 functions. They carry oxygen, they expand the circulating volume. That's all they do. So you should look at them as being a drug, and you should look at them as being a product that carries oxygen. One of the products doesn't require refrigeration, that's Hemopure. The other one does. Neither require cross-matching. They have no cell walls, so they are universal donor products, both because they're acellular, have low viscosity, and they improve rheology in ischemic situations. But they have very, very different physiological surface properties and biochemical properties. Just as a simple example, Hemopure has a hemoglobin of 13 grams per deciliter. I think you would say 130 grams per liter. MP4, 4 grams per deciliter. So they're very different products, and the design of the products, MP4 particularly, is sort of counterintuitive because it has a P50 of 5 millimeters of mercury when blood has a P50 of 26 millimeters of mercury. So it has very high oxygen affinity, very low hemoglobin value, and you think, well, why do you want to do that? The design was to try and minimize the binding of nitric oxide. The feeling was that you didn't need a lot of hemoglobin. If you had less hemoglobin, you wouldn't get so many interactions with nitric oxide. And really, if you were able to deliver 4 grams per deciliter of hemoglobin to the mitochondrial level, the diffusion gradient is quite significant, and therefore you wouldn't have to have oxygen affinity wouldn't be a problem. The hemoglobin would still give up its oxygen, even though it had a very high oxygen affinity. So that was the logic behind the design of that product. And here's a comparison of the different. There are only two currently available products, Hemopure and MP4. The other products, Polyheme, Hemocyst, all the other ones you may have heard about, have fallen by the wayside and are no longer produced or commercially available. The Hemopure is a bovine product, glutaraldehyde, polymerized product with it's iso-oncotic and isotonic, whereas MP4 is hyper-oncotic, and it has larger molecular size, so it is retained within the circulation for longer than Hemopure. It also was thought by this design to minimize the extravasation of the product. The hemoglobin concentration, 13 versus 4.2, methemoglobin concentration, more methemoglobin in Hemopure than in MP4. And the half-life is longer in MP4 than it is in hemoglobin, about 60 hours for MP4 versus about 19 hours for Hemopure. So they're very different products. The advantage, of course, of Hemopure is that it doesn't require refrigeration. So it has a shelf life of 3 years with can be stored at 2 to 30 degrees centigrade, whereas MP4 has to be refrigerated. And in certain parts of the world, that's going to be very difficult to do. So have the hemoglobin-based oxygen carriers been adequately tested, and are they safe? Hemopure's had 22 clinical trials with more than 800 humans receiving the product and more than 1,000 controls. It's had 4 phase 2 and 3 prospective randomized clinical trials, and more than 1,000 patients have been involved in those trials. The mortality in all the trials is not different versus packed red blood cells, and it is approved for human use in South Africa and in Russia. MP4 has had 6 clinical trials. It's a more recent product, 85 humans receiving the product, 46 control patients. 1 phase 2 trial has been completed, and 1 phase 3 trial we're awaiting the results of that. There's been no regulatory approvals of that product. So looking at the prospective phase 3 prospective randomized clinical trial, the HEME-115 of Hemopure, looking at avoidance of red blood cells, you can see that and this was the FDA allowed a dose up to 10 units of hemoglobin-based oxygen carrier. And then you had to cross over to packed red blood cells. In the HEME-114 trial, they allowed up to 6 units, HEME-115 up to 10 units. The red cell avoidance at 6 weeks in the HEME-115 is about 60%. HEME-114 was about 43%. So day 1, 96% transfusion avoidance. That gives you plenty of time for a blood bank to look around, find blood if there's a blood shortage. A week, 70.3%. Most people, that's adequate time for them actually to start generating their own red cells. So potentially avoiding blood in that situation. In 6 weeks, 60% avoidance. Mortality, not in the intent to treat analysis, was not different. They were, however, if you see in the table on the right-hand side, more adverse events and more serious adverse events in the patients given Hemopure than those given blood. But the data monitoring board said that the product was not, they're blinded, they said it was not inferior to red blood cells in overall medical risk. So there was, however, a problem with a certain group of patients in the HEME-115 study, and that was those patients who were greater than 80 years of age, when they had an increased mortality in the patients randomized to the product. And there were three things that appeared to be related to that. One was fluid overload, and many of you in the audience will remember the days we used to use whole blood. And if you recall, pulmonary edema was a problem with the use of whole blood. And this was the case in this situation with Haemopure. And when we used whole blood, we used to give these patients Lasix. And again, that was, I believe that's what should be done in this situation when using Haemopure. You have to diurese these patients to prevent fluid overload. The same thing was under treatment. The clinicians in the trial looked on this as being the equivalent to blood. So didn't really fully appreciate the half-life and the need to redose these patients after the first administration of the product. And then the third thing was that there is a large difference in the total hemoglobin concentration in a unit of Haemopure versus a unit of packed red blood cells. And I'll say something about that in a moment. So when we looked at the data in those patients, and this would be a pure comparison between packed red blood cells up to 3 units, which is equivalent to about 10 units in total hemoglobin concentration, versus 10 units of packed red blood cells, 10 units of HBOC, which is the total amount we're allowed to give. So a pure comparison between those two, mortality was identical at 1% in those randomized to the packed red blood cells versus the 10 units of HBOC, and the serious adverse events per patient was also identical at 0.14. But you'll see, and the trace shows you at this point here, the transfusion decision was made and the patients were randomized. You'll see that the patients who received Haemopure, which are showed down here, really, for most of the time, did not exceed the level at which the transfusion decision was made. So they were undertreated during the course of this, whereas the patients who got red cells had much higher hemoglobin concentrations. So, and we know anemia is a multiplier of mortality, and my thought is that the elderly patients of 80 years and above had multiple pathology going on. If you take no heart failure, chronic kidney disease, or anemia as being a value of 1, then if you add all those together, you multiply the mortality 6 times. This is from the Medicare database of just over 1 million patients. So each time you add one of these things, anemia or heart failure, you increase the likelihood of mortality. We also found that modeling the effects on total hemoglobin of the administration of 1 unit of the product versus 1 unit of packed red blood cells, you'll see that we found that the model predicted that we get a rise of about 0.2 grams per deciliter. We actually observed in patients who received 1 unit an increase of 0.18, so the model was pretty accurate in that sense from Haemopure. And for packed red blood cells, we saw an increase of about 0.8, and that was actually observed about 0.87. So relatively speaking, the packed red blood cells were about much more effective, 20% less effective. That Haemopure was 20% less effective than red cells in increasing total hemoglobin. Blood pressure did go up, approximately 15 millimeters of mercury. Systolic blood pressure lasted, generally speaking, the half-life of the product. 1 patient out of the 350 randomized to Haemopure did have a serious adverse event and sustained hypertension that had to be managed appropriately. The follow-up, though, was at 6 weeks, no difference whether or not they had been randomized to Haemopure or packed red blood cells, suggesting that this is not the disease hypertension. This is something related to the administration of the product itself. And there are many different ways that this has been suggested as causing hypertension. Obviously, nitrous oxide binding is one of them, autoregulatory changes, increase in endothelin, and various other things have been suggested as mechanisms for this increase in blood pressure. What about hemospan, or MP4? The 6 trials that have taken place, elective surgery, limb ischemia, prevention of hypotension after use of spinal anesthesia. Has shown in the phase 2 trials in orthopedic surgery, where they're looking at spinal anesthesia and reversing the effects of hypertension, there was an imbalance in the serious adverse events. Again, similar things, including bradycardia, increase in blood pressure, GI symptoms, suggesting again that despite the attempt to try and minimize nitric oxide binding, that still seems to be a problem. It was successfully tested against heterstarch to treat hypertension. Seems to me a very expensive way to do that, but that's what they did. That was their primary outcome objective. The secondary objectives were to reduce the operative and post-operative morbidity, and that did not occur. There is a trauma trial looking at patients who have high lactate and looking at the ability of this product to reverse the lactic acidosis. That trial, the website there shows, we haven't seen the results of that, but the word on the street was that it did not achieve that objective and that they're actually reformulating the product. So most of my stuff, unfortunately, refers to the use of Haemopure. So why haven't these products been approved? They haven't been approved because the FDA thinks that this meta-analysis was a significant reason why they should not be approved. And the meta-analysis stated that they believed that all hemoglobin-based oxygen carriers caused increased myocardial infarction, increased mortality, and that this was a class effect. There were 4 letters written to JAMA. I was not an author of any of these letters, but I'll tell you what they basically said was that there were 16 prospective randomized clinical trials, 5 different products, and they had different comparators. And of course, if you're doing a meta-analysis, that is an inappropriate methodology. They compared to blood, compared to plasma, compared to crystalloids. The 5 products had very different pharmacological, physical, and surface properties. So it's really pharmacologically unlikely that there's one class effect. 22 separate trials with HBOC 201 were considered as one for the meta-analysis. Again, they all had different comparators, not appropriate methodology. And the data from HEME 114, which was not even included in that meta-analysis. They did include 2 products that have been removed from the market at least 10 years previously. If you take the HemoAssist product, that's the alpha crosslink product produced by Baxter, out of the analysis, there is no mortality and myocardial infarction difference. And then if these products are toxic, there should be a dose response. There is no dose response. So there are some limitations in this criticism, but nonetheless, the FDA has still not approved a hemoglobin-based oxygen carrier in the US. That these products can reverse myocardial ischemia is shown in this case report published in the Medical Journal of Australia. You see that the green plot shows the troponin levels. This patient had a hemoglobin drop down to about 3 grams per deciliter, and the troponin levels increased 3-fold. The administration of a hemoglobin-based oxygen carrier normalized these troponin levels very rapidly, suggesting that they reversed the ischemia, of course. The mechanism shown in this graph here is that in normal states, of course, hemoglobin is contained within the red cell. Doesn't leak out. But in toxicity situations such as drug reactions, such as transfusion reactions, such as sickle cell disease, then free hemoglobin leaks out. And the bar across the top shows you the quantity of nitric oxide being available. And then on the right-hand side of the trace, if you then infuse a free hemoglobin, you further bind nitric oxide and reduce the amount that's available. There are many mechanisms suggested for the toxicity with and without nitric oxide. We do know that free hemoglobins will bind endothelial nitric oxide and will produce vasoconstriction, also causes heme loss, causes free radical formation, lipid peroxidation, and you do get met hemoglobin being formed. Impaired blood flow also creates a problem, uncouples the endothelial nitric oxide synthase. So, and then pressure effects from adrenergic stimulation may give rise to some of the blood pressure effects you see with hemoglobin-based oxygen carriers. So what's the future? Well, the future actually hangs very much on the trial that has just been approved at the Alfred Hospital in Melbourne. And this is a pre-hospital trial that has been designed as a phase 2 prospective randomized trial. Just over 100 patients will be randomized either to normal saline or to hemoglobin-based oxygen carrier in the pre-hospital phase. And the transport times in Victoria are much longer than we had used to in the USA, so there is a potential opportunity for these patients to benefit from the use of a hemoglobin-based oxygen carrier. The entry criteria include shock index, which is closely associated with the use of blood. A shock index of 1, very nice and easy to calculate, will be amongst the entry criteria. Obvious hemorrhage and injury and unresponsiveness to the initial bolus of crystalloids. And the patients will then have outcomes measured on arrival at the trauma center at the Alfred, looking at mortality, cardiac arrest, anaphylaxis, acute MI, and ischemic stroke, and then looking at the shock index on arrival at the Alfred, looking at venous blood lactate, pH, and bicarbonate, and prothrombin time, as well as the amount of blood and blood product administered and the length of stay in the Alfred Hospital. So I think this is a pivotal study for hemoglobin-based oxygen carriers in general and will determine the future direction. If this study is not successful, then I think the whole use of hemoglobin-based oxygen carriers may cease. And we will have to redesign them, go to a third generation of oxygen carriers, and start looking at what alternative ways there are to minimize some of the toxicities. So when we summarize and think, now is Hemopure, which is really currently the only viable product, safe and efficacious? Let's look at what the things are. There's no mortality difference when they were randomized to Hemopure compared to packed red blood cells in the intent to treat analysis. In moderate needs, that's up to 3 units equivalent of packed red blood cells, which you remember, 2-unit transfusion was the most commonest mode of transfusion in trauma. Then the SAEs were identical and mortality were identical. You get 96% avoidance, so plenty of time and within 24 hours to find some blood if the patient will receive blood, and that myocardial infarction, certainly with the use of Hemopure, was actually less with Hemopure than with blood. So these data and the compassionate use experience suggest that this is a product that would be life-saving when blood is not available or an option. So it all boils down to risk-benefit ratio. The risks are there are higher incidence of serious adverse events with the product. And in greater than 80-year-old patients, there is an increased mortality. But the benefits are that if blood is not available, then this is a product that can sustain life and can sustain the delivery of oxygen. So I think the message really is that you have to look at the context of the use of the product, and the benefits must be considered in relation to the risks of doing nothing, and of course the risks of doing nothing include death. So the question really is for you, the clinicians, will the clinicians accept the risks or refuse the benefits? Thank you very much.